Good evening and welcome to Doctors on Call. Tonight our panel of medical experts will be taking your questions about the diagnosis, treatment, and potential complications of diabetes. I'm Dr. Ray Christensen from the Department of Family Medicine and Community Health at the University of Minnesota Medical School, Duluth, and I'm your host for tonight's program. We're ready to take your questions. Please give us a call at 218-788-2844 or toll free at 1-877-307-8762. Here to answer your questions this evening are our panelists, Dr. Gail Baldwin, a family physician with the VA Clinic in Superior, Wisconsin, Dr. Bruce Henson, an endocrinologist with Essentia Health Duluth Clinic, and Dr. John Wood, a family medicine physician with the Duluth Family Medicine Clinic. Our medical students answering phones tonight are Sarah Cruz from Zumbrota, Minnesota, Aaron Mustonen from Little Falls, Minnesota, and Alexis Quaid from Westbrook, Minnesota. And now, on to tonight's program on diabetes. Dr. Baldwin, we need to kind of probably just build some basic foundation. What is diabetes?
Well, diabetes is a condition where the body doesn't manage sugar properly. It can be because there's too little insulin or because the body isn't responding to the amount of insulin that is in the system.
Are there more than one type of diabetes?
Well, there are more than one type of diabetes, but the two that are most commonly associated with sugar problems are diabetes type 1 and diabetes type 2, where type 1 is the time when the insulin isn't present, and type 2 usually is there's plenty of insulin around, but the body's not using it very well.
And type 2 is kind of more us older people get that type?
They used to call that the adult onset diabetes,
Yes.
although it doesn't wait for adults sometimes.
Yeah, I understand it's becoming more and more prevalent even in younger people. Dr. Henson, do you see any of the children or young adults?
You know, when I started in practice a few years ago, I would get calls from pediatricians with questions about type 2 diabetes because they just never saw it. And now there are whole clinics in children's hospitals and pediatric practices to take care of the growing number of kids with type 2 diabetes. So Dr. Baldwin's right, we can't call it adult onset diabetes anymore. It's increasingly frequent in the younger folks.
Dr. Wood, just to help us out, how do we diagnose diabetes? What are our criteria?
A couple of different ways. First would be just a standard lab value, like a fasting blood sugar. Anything over 126 would be, you take a certain test in the morning where you haven't eaten anything in the morning, a blood sugar over 126. Or a random glucose, let's just say you walked into the doctor's office and said you had some of the symptoms of diabetes, which would be excessive thirst, maybe weight loss, you don't feel very good, and your random sugar was over 200. They just did a blood test in the office. That would be another way to diagnose that. Or a test called an A1C, which you've probably all heard of. Hemoglobin A1C looks at the proteins and the glucose content on the outside of a red blood cell, and if that's over 6.5, anything below 5 being normal, then that's also a way to diagnose diabetes. So there's several different ways to do it. And then pre-diabetes, which is kind of the precursor to diabetes, your sugar would be anything over 100, your fasting sugar between 100 and 125. So there's a few different ways.
Dr. Henson, as an endocrinologist, there's a lot of discussion about where diabetes really starts. And pre-diabetes is in some ways just softening us up to the real truth, isn't it?
Well, yes. I mean, diabetes, we think, develops from a combination of circumstances. It's an inherited trait to develop insulin resistance. The body has a harder and harder time utilizing insulin efficiently to deliver glucose out of the blood into cells. It's an inherited trait that tends to worsen as we get older, which is why it's more common in older people. And it's exacerbated by obesity. So it comes on gradually as a result of all of those factors. The earlier it's discovered and interventions are undertaken, the easier it is to prevent its progression. So prediabetes is an important concept because when we find patients in that category, there are some things that we can initiate early on that helps retard that inevitable progressive nature of diabetes. So prediabetes is an increasingly important category of patients that we like to find get started on intervention early.
So now that we're at that point, Dr. Baldwin, Over at the VA, you're seeing a lot of, mostly men, I would guess, but some women too. How do you handle your newly diagnosed diabetics? But maybe if we just start with someone over 100, the pre-diabetics, what do you do?
Well, first it's lifestyle counseling. Basically, if these people are exercising daily or at least regularly, getting their pulse rate up and doing enough exercise to sweat on a regular basis at least 3 times, if not every day of the week. If they're not eating a healthy meal, so that means a lot of vegetables and proteins as well as some carbohydrates. Those are two places where they can make a great deal of difference. And then looking for a healthy body weight, someone with a BMI under or no higher than 25.
Ooh, that's pretty small.
It's hard to achieve and to sustain, I have to say, for some of us.
Dr. Wood, when do you start medications? Dr. Baldwin has talked about the physiologic aspects and diet. Where do medications fit in?
Well, medications have a great role because it's, maybe think of it as a 3-legged stool. You do you have to do your diet, you got to exercise, but there's a certain point where you might need meds. Let's say your sugars, your A1C is consistently probably over 7%, and you're not able to keep it lower than that despite trying to follow your diet and exercise, and there would be a role for meds. And often in a pre-diabetic, sometimes there's a role for a certain drug called metformin even in the beginning. But you'd start with, if you're not able to do that with diet and exercise, then you're going to need some help. And that's usually in the form of either an oral med or insulin, one of the two.
Dr. Henson, I seem to remember that there's a lot of discussion about, and I think you brought it up a little bit, the earlier diagnosis, the better, and doing something up front. So being more aggressive early on.
Exactly, yeah. So this pre-diabetes state, lifestyle modification, as Dr. Baldwin outlined, is very important, and it is achievable. Studies tell us that if patients at that stage can lose 5 to 7% of their body weight, they can decrease the chances of that process progressing on to diabetes by 60%. So making a concerted effort to help these patients change their eating habits and their exercise habits and work on even modest weight reduction can be a big improvement. And then the medicine that Dr. Wood mentioned, metformin, in that same group can also retard the progression on to overt diabetes by as much as 40%. So getting an early start makes a big difference.
I'm going to pull us back just a little bit, Dr. Baldwin. We talked about the different types of diabetes, and one person would like to know what juvenile diabetes is. So maybe just the difference between type 1 and type 2 or juvenile.
Okay. Juvenile diabetes, at least that term was always used to be type 1 diabetes, where the body isn't making enough insulin, and it has to do with the pancreas not putting out enough insulin. Unless something has happened since I learned about it, we still don't know for sure what causes that to happen, but it can happen at any age really, but it's more common in children. So juvenile.
Dr. Henson, any?
Yeah, it's what's called an autoimmune disorder, where the immune system, for some inherited and environmental reasons, suddenly turns against the insulin-producing cells in the pancreas and begins to destroy them. And Dr. Baldwin's right, we don't understand exactly why that occurs. It's an inherited trait that some factors seem to trigger and slowly destroys ever-increasing amounts of those insulin cells until finally there just aren't enough cells to make insulin and control the blood sugar and type 1 diabetes.
There's starting to be some discussion on the A1C levels in the questions that are coming in. There's been discussion, at least in my clinic, and I think among many of us, as what's the optimum A1C level. And I think as an endocrinologist, you may have a different view than we as family physicians. Woody, do you want to jump in on that first?
Sure. I guess I'll go with probably like most things, what's ideal depends on the person, but the Minnesota core measures is kind of a standard sort of measures of optimal healthcare say that an A1C of less than 8 would be the goal you're shooting for. And Bruce, I'm not sure the exact what that correlates with the sugar, but it's probably around an average blood sugar around 180 or 190, somewhere in there. And so at our clinic, we like to see people a little bit tighter than that, maybe in the below 7 or around 7, which is pretty darn good if you ask me. So that's kind of the number we're looking at. But I think it varies from person to person, meaning doctor, provider to provider. But I will say that the standard measures say that, at least in our state, you got to be below 8%.
I would say also that it depends on the individual, because the better blood sugar control, to a certain degree, the less side effects that are potential to come from diabetes. Sure. And so if you have an early onset diabetic type 2 with the ability to control their sugar and keep their A1Cs in the 6 to 7 range, I like people to shoot for that. But if I have somebody, for instance, I have a lot of people who are octogenarians who in their 80s, if they go very low, which can often happen with some of our oral agents or insulin when they're not eating properly, and their blood sugars go really low, then that's more dangerous, I think, than the blood sugars that might be running a little higher and closer to the A1C of 8. So, like you said, it depends on the individual, and I think we as doctors are also more comfortable given our populations. Sometimes we have a population of people who can shoot for lower numbers. Sometimes we have a population that we might want to shoot for higher numbers.
Dr. Henson, where does endocrinology come down on this?
Well, I think Dr. Baldwin's exactly right. I think you have to individualize the target based on the patient's overall clinical picture and other potential risk factors. So, for example, in a very young woman during pregnancy, we would shoot to get their A1C clear down into the normal range, under 6. For the older, frail, elderly person with vision problems and gait instability and on multiple medications, you become a little less concerned about trying to forestall complications that might occur 10 years down the road and more concerned about short-term complications from over-intensive therapy, and so you might shoot for an A1C 8 or even higher sometimes. At least in type 1 diabetes, the incidence of those long-term complications that Dr. Baldwin alluded to begins to rise when the A1C is above 7. So for the general population, other individual factors aside, I think a good target is to try and get as close to 7 as you safely can in terms of trying to minimize some of the chronic complications.
Great discussion. Thank you. How else, this is a really interesting question, how else can you develop diabetes? If you eat well, manage your weight, can it only be inherited? So if someone is doing all of the right things, can they still get type 2 diabetes? Who wants to jump on that one?
I would say, unfortunately, probably you can. And unfortunately, it is probably heritable. Or potentially, I guess, type 2 would be harder to do with toxins. But we think that Agent Orange exposure may cause people who otherwise might not have developed type 2 diabetes to develop type 2 diabetes when their family history would indicate that it is not so likely.
And yeah, just another thing, diabetes regulation is incredibly complicated, I would say, and I know that a lot of people who have sleep disorder or don't have shift work, I can speak to myself who had an elevated sugar because of lots of night work I was doing, and that changed once I was able to get back on more of a regular schedule. So I would say that yes, even though if you do all the right things, there are things that can happen, environmental factors and or genetic factors that you can't control.
I think it's important to realize, though, that it may not be entirely preventable, but it's certainly modifiable, and you can have a great impact on trying to prevent or at least retarding the progression of diabetes. So I encourage patients not to have this sense of inevitability and hopelessness. You can have a tremendous impact, but you can't guarantee that you can prevent it, no, even with the best of efforts.
Let's just take a little bit of a side. How do those real fun things that we do, alcohol and cigarettes, how do they affect diabetes? Woody?
Well, I'll start with alcohol. Alcohol's got a lot of calories, a lot of, probably, and often when we're drinking, we might not make the best dietary choices, so we might put on a few extra pounds. Over time, that might catch up with us. Cigarette smoking, we were having a little discussion among the four of us prior to the start of the show, and the conclusion, I won't mince words, is that cigarettes are incredibly detrimental to your health, even in the best of circumstances. And diabetes sets up on a molecular level a lot of inflammatory responses that are just exacerbated by cigarette smoking. So, and big issue with diabetes, one of the big complications, of course, aside from kidney and eye problems and nerve problems, is it's a big major risk factor in heart disease. And the combination of smoking and diabetes is a major killer in the U.S. Cardiovascular disease is the #1 killer in women, for example. And so smoking just exacerbates the whole thing. It's like throwing, gasoline onto a lit fire, basically.
So we've stimulated a little discussion about prediabetes in the questions too. For someone who is pre-diabetic, so at 100, is that pre-diabetic at 100? That was one question.
Yeah, fasting blood sugar over 100 is not normal. Now, blood sugars, of course, can change day to day or under circumstances and whatnot. So I don't know that it's particularly helpful to have an arbitrary cutoff. You cross the line, that's it. It's a spectrum, it's a progression. You can make that progression run either direction, but if your fasting blood sugar consistently running over 100, that's not normal.
As Ben Owens used to say, sit down and talk to your family doc about this and have a discussion.
Yeah.
If someone is pre-diabetic, does cutting out alcohol help? So if you're sitting with that 100 to 126.
Yes, because I would say, depends on how much alcohol you're drinking. I think that's the first discussion you want to have. And also, if you're thinking about modifiable things, diet and exercise, alcohol being part of your diet, I would say that's how I would approach that. I mean, we're not Puritans here. You got to live, you got to have, things that you find enjoyable in life are still important, but certainly modifying your alcohol intake, if that was an issue, would be something I would do.
There's been a couple of questions about the pancreas. One is the pancreas transplants. England has done some. I think we've had transplants here also. And then the artificial pancreas. And I don't know who feels qualified to enter into that discussion. I know, Bruce, we'd all look at you, but either of the other two of you.
Not me, Gail.
I'm sorry, I'm not qualified.
Yeah, actually, one of the pioneers of pancreas transplant was right here, University of Minnesota. The transplant team there, along with an endocrinologist, David Sutherland, pioneered pancreas transplant decades ago, and they have become increasingly practical, but not entirely available. Like any other organ transplant, after a pancreas transplant, you have to take immunosuppression medicines, which have a number of potentially toxic, life-threatening side effects. So if you have liver failure that could kill you, heart failure that could kill you, an organ transplant can save your life, and it's worth taking the risks of immunosuppression to get that advantage. If you have type 1 diabetes and your pancreas is being destroyed, the insulin cells, by this autoimmune process, you don't die, you have to take insulin. So it changes the balance, the risk-benefit balance for immunosuppression. But it's still commonly or regularly performed in conjunction with another organ transplant, such as a kidney transplant. Patients with diabetes often develop kidney failure, as Dr. Wood alluded to, and require a kidney transplant. In conjunction with that, they take immunosuppression, and so then adding a pancreas transplant to that process doesn't add to their immunosuppression risks, and that's probably the most common context in which an organ transplant is performed. Islet cell, really all you need are the insulin-producing cells, though, so there's a lot of research going on trying to identify ways just to give patients the insulin cells from the pancreas rather than the whole organ transplant, or ways to develop better insulin pumps that will essentially become sort of an artificial pancreas. So there's a lot of technical research going on in that insulin replacement arena, either with organ transplants or with technology.
So the comment, one of the questions was the synthetic pancreas, which probably is more or less the insulin pump, isn't
Exactly.
it? Yeah.
Yep.
Is there a connection between diabetes and sleep apnea, Gail?
I don't know the answer, although I would suspect that anyone who is predisposed to develop diabetes type 2 with the stress of not getting good sleep is more likely to develop diabetes type 2 or show the signs sooner.
Right. And those patients, of course, are frequently quite a bit overweight, which is another risk factor for type 2. So I think there's certainly a higher likelihood of seeing type 2 diabetes in patients with sleep apnea, and conversely, the sleep apnea can certainly worsen the blood sugar control.
Woody, you started with the kidneys. What about heart disease risk? I think maybe just to explain that a little bit more. Pre-diabetes, I think the risk of heart disease goes up.
Right.
It becomes a risk factor, a major risk factor. And what are some of the other complications and concerns that we have with diabetes?
Well, Dr. Henson alluded to that. You can have kidney issues, basically the opathies, you could say. Retinopathy can affect your eyes. That's why if you have diabetes, it's important to see an ophthalmologist or an optometrist for a yearly checkup to look at your eyes. Kidney factors, you can get kidney failure from diabetes, and that's because on a molecular level, the diabetes, the high blood sugars are affecting cells in the kidney, particularly they're very sensitive. Or you can develop nerve problems, like a lot of diabetics have neuropathies. I'm pointing to my feet because that's a fairly common place that it starts, meaning that they have painful feet, painful legs, and that's why there's numerous medications to help with that. And that again is from microscopic or molecular damage to the nerve cells that are causing those painful sensations. So diabetes, you can think of these triopathies, meaning these three problems. And like Dr. Henson alluded to, you control your sugar, you're trying to prevent that. It's kind of a race. You're trying to make sure that the complications of diabetes don't catch up with you. And the way you can do that is by just doing a good job managing your diabetes on a day-to-day basis.
There's a biome question here about gut flora. We're hearing more and more about the bacteria that we all harbor and how that affects us. Does changing the microflora of the gut have an impact on diabetes? And I don't know of any studies that have been done on that, and I guess I would just follow your direction.
Yeah, I think we're kind of early in the understanding of gut microflora. We're actually learning more about gut hormones. There are a lot of hormones produced by the gut. It's almost like another endocrine organ, and so we're learning more about how those hormones work and actually utilizing that for developing medicines to take advantage of gut regulation of food digestion and insulin secretion. But I don't think we know too much yet about how the gut microflora fits into that whole picture yet.
At what stage is an insulin pump necessary? I don't have an answer for that one.
I don't know that it's necessary. I think that sometimes people find an insulin pump is a way that they can control their diabetes better because the insulin's right there, they're carrying it with them all the time, they're monitoring regularly. But if you have an insulin injector, you can do the same thing.
Is there a correlation between gestational diabetes and diabetes later in life?
It appears
the answer
that
is yes, I think. But
Yeah, gestational diabetes, pregnancy creates a version of insulin resistance, and so if you have an underlying insulin resistant trait, sometimes the added stress of pregnancy will bring that out, and it can resolve after delivery, but a high percentage of those women go on to develop type 2 diabetes later in life, 30% or more. So it can be a kind of a warning sign.
Question on the dawn effect. Why is the blood sugar higher in the morning and then stabilizes during the day? If any of you want to touch that one.
We think it's in part due to the production of some of the other hormones that get secreted early in the morning. As we get waking up and getting ready to go, we produce more cortisol and growth hormone, which kind of counteract normal insulin effect. And so there's this what are called counter-regulatory hormones that actually work against insulin in the early morning hours, and then they subside as the day gets going.
I want to thank our panelists Dr. Gail Baldwin, Dr. Bruce Henson, and Dr. John Wood, and our medical student volunteers, Sarah Cruz, Aaron Mustonen, and Alexis Quaid. This has been a really good discussion, and I really thank you very much for this discussion tonight. Please join me again next week for a program on circulation and leg problems. My panelists at that time will be Mark Eganton, Dr. Emily Onello, and Dr. Gregory Snyder. Thank you very much for watching. Good night and Happy New Year.